So lots of exciting stuff behind the growth of RPM, CCM, and APCM in 2026. It is we're seeing sort of a huge uptick in interest in general. If you've been on the fence in these programs, it's a good time to start them. Margins are higher. There's more flexibility than there's ever been. There is ample evidence that there is a lot of support behind these programs. They're not going anywhere anytime soon. And, keep your nose clean, but generally worth doing. So with that said, how are you successful or most successful in 2026? So one is you have these new codes. You got to make use of them and make sure that you're using them for good. First, that 2 to 15 monitoring days code. Now you can align RPM with clinical need. So if you're doing hypertension and maybe they're already titrated, their medication's titrated, you don't need to see 60 measurements. You can tell them to do it twice a week. It is now up to the physician or the mid-level or whoever's supervising the program to decide what is clinically relevant and make sure the patient understands that and you're communicating with the patient that, right? So twice a week might be great. Maybe they do monitor every day during the initial, when you're going through how to medicate and things like that, getting it under control. But then you can change it. It also allows you to have more brief clinical interactions because that 10 second, geez, that would be an issue. 10-minute code, right? But most importantly, maybe it really expands it out to new clinical scenarios and modalities. We're getting a ton of interest for weight loss in GLP-1 clinics. It was difficult to get a weight loss patient to weigh themselves 16 days a month. And not only that, it was almost clinically like counter to the clinical relevance, right? Like you're not going to see much change that quickly. So it's almost bad for the patient to just be staring at the scale while they're trying to make major improvements to how they're doing things. So maybe 3 times a month or once a week is perfectly legitimate for weight loss. Alternatively, for heart failure, if you're doing the same scale, right? But now you have a heart failure patient, they should be weighing themselves every day, every morning at the same time. So this allows a lot more flexibility to new clinical scenarios, but you also don't want to give up the measurement sort of amounts when you're doing conditions that really behoove it. Post-acute and inpatient transitions, another thing that you might not need that many measurements. Maybe you only need to measure the patient for 15 days. Well, if you're only measuring 15 days normally, a 30-day period, 60 measurements doesn't help you. But in this case now, if you're doing it for a few days, you can still bill for that month under the 2-day code. We're seeing some of that as well. So aside from RPM, you also have to now choose between APCM and CCM. And there's a few different reasons and ways to sort of consider this. APCM takes less work, just in general. The idea with APCM is it's really a population level code. Medicare is going to pay you for all your patients who are enrolled as long as you offer certain aspects, and we're not going to go through each one of those sort of features of it in this call. That said, it is the idea being that you're going to spend significant time on patients that need it in any individual month, but you're not going to spend 20 minutes on every single patient every month. You get paid less for less high acuity patients. You get paid more for higher acuity patients, and you get paid a lot for qualified Medicare beneficiaries, right? With 2 or more conditions if you have them. One big takeaway here is you have to be the provider primarily responsible for that patient's care. So if you are a specialist, like a cardiologist, you can still bill for it, but the patient has to be going to you basically as their PCP, right? You don't have to be a PCP as far as being like internal medicine, family medicine strictly, but you have to be the primarily responsible provider for that patient, not just for their care for just that specialty, right? For just their cardiac health. That said, this is being utilized a lot more. CCM, on the other hand, can be done by a specialist as well, as long as there's 2 or more chronic conditions that are being managed. you can get more money per patient. That said, you're spending way more, you're spending time with the patient. Every single patient, you need at least 20 minutes to bill. So the idea here really is to balance it. You can also do it with different patient populations. We don't suggest switching patients back and forth like month to month over and over and over again. That said, if you have higher acuity patients and lower acuity patients, CMS gave the flexibility to sort of to adjust this based on your populations and use them somewhat, not interchangeably, but sort of decide which patient should be on which we weren't sure if would stick, but CMS seems to be okay with that given the guidance that they put out so far. We have seen a lot of practices change to APCM for the vast majority of their Medicare patients, and then using RPM on top of that for the patients that need it. And so you end up with APCM reimbursement. You're still going to be spending some APCM time on some patients, but for a lot of the time spent, you can use RPM care management codes as long as it's related to the device or that condition, and you end up getting benefit of both the patient and then the billing looks higher. That's our recommendation if you're for most PCPs and groups that can do the APCM codes at this point. That said, your mileage may vary. So the other thing that's important is choosing the right solution, really the right vendor in some ways, but also maybe the right vendors if you're using different vendors for different things. So basically, there's three aspects of this that I normally think about it, right? First off, you have the software. Can you do it through EMR? Well, for a few patients, maybe you could do RPM CCM and EMR with 20 patients, 30 patients. Can your EMR scale it? Does it have the automation? When should you switch to a sort of comprehensive software, and which comprehensive software should you choose, right? These programs, when done at scale, are when they really start benefiting both patient populations and becoming, revenue generating sort of programs. And at scale, the vast majority of EMRs that we have seen start having issues, right? Some of our biggest customers, and this is as an anecdote, are getting 110,000 readings a month. I think one is between 60 and 80. On average, it's still over a couple thousand. So these aren't the kind of programs where you're staring at every measurement coming in. And most EMRs, that's what you get, is just a chart. And here's the measurements. Nurse better look at them. Otherwise, they're either going to alert all the time, every measurement, or they're never going to alert, and you better just remember to look at your patients. What you need usually for these things at scale is something that can distill down those measurements and all the other information flowing back in, aggregate it, and make it actionable alerts and data. You get longitudinal reports at the end of each month, so you can look at changes over time. You get alerts when there's things that need to get your attention relatively quickly. These programs are usually not like real-time monitoring where you're monitoring like vitals like a hospital home thing. That said, you probably want to know when a patient should have medications changed, or when a heart failure patient starts taking on, retaining fluid, things like that, right? And on top of that, as you scale, and some groups, some of the larger groups don't want any AI things turned on, and that's fine too, but you probably want some AI-powered tools, mostly now for quality of life, summarizing things, helping take notes for calls, alerting things and figuring out things like billing compliance. It's not supposed to be a sales call, obviously, but we now have AI that sort of can check through some of the compliance aspects, right? That's going in as a beta, things like that. There are predictive analytics and stuff that is going to come out for the future. There's some FDA sides of that, and there's a lot there. That said, AI can make your life a whole lot easier when you're doing this at scale by just going through and helping with, general management and overview. And then finally, compliance. Compliance, as I talked about before, is becoming more and more important with these programs. So something that you should be making sure that, it's compliance first when you're doing the software. Going through this really quickly, devices, if you're doing RPM, devices are very important. You want super easy to use devices. Most of the patients on these programs are older and less tech savvy. We have a few that are in greater San Francisco, where somehow every Medicare patient has like an Apple Watch and is, moving and grooving. That said, the vast majority of our patients are in areas that are just not super tech savvy. And you want to make sure that they put the batteries in the device, they work, and, the tech support is there if they need it, but you won't need it as much as you otherwise could. Same thing with shipping and logistics. Do you want a pallet of devices in the back of your clinic? Maybe you're welcome to have that, but probably not. In that case, can somebody ship for you? Can someone take returns? All the logistics stuff, right? Press button in the platform or EMR, get the device sent out. You just get the measurements back, all's well. And then device technical support for patients largely, right? You want the patients to not have to be having trouble getting help and support. And also generally, you probably don't want to be the one that's doing the technical support, right, out of your clinic, or at least not the majority of it. Maybe the first line of it is, make sure the batteries are in right, but not the like heavy duty stuff where that's an issue. On top of that, I'll go into outsourcing in this next slide. That said, with services, if you want outsourcing, it's important, obviously, that it's done right and that, it's sort of, I'll talk more about that in a second, so I won't go too far here. But outsourcing services, if you want them, got to make sure those are there. But then also, almost as important, even if you're doing it internally, operational and workflow support. How do you build the workflow for these things into your practice where it's not encumbering your staff, right? At what point in scale do you want to start thinking about getting an FTE? Doesn't have to happen at first, but 1,000 patients, like at some point, when is the program paying for, it pays for itself, but paying for somebody to manage it as sort of their main job? How do you do the billing at the end of each month? All that good stuff, right? And then compliance. So making sure that you have a partner that's not just sort of arms length software, important. Making sure that you have the devices, and you can use 3 vendors for this. We always say that it's kind of a good thing usually to have sort of one vendor to both blame for success or failure, right? With all these different aspects. That said, there's plenty of groups that also do it with a device vendor or a software vendor. And onward you march. Big decision, staffing model. So these services are some of the only, and might not the only, but they're some of the few services that Medicare allows to be truly outsourced under general supervision. So not outsourced as in, I give this away to a third party and they bill themselves or their own clinic. That is, some groups do that. That has become clearer and clearer. Maybe at the very least, we'll say discouraged. The OIG seems to think that it's not kosher, but also there's not been a ton of audits against it. But the big sort of takeaway generally is you want to be the one billing. The clinic should be the one billing. If you do outsource it, the folks who are calling your patients that are not in your clinic are your agents still. You still have general supervision. You're outsourcing that labor of ring patient, how you feeling this month? But really, you're still the one that's doing general oversight of the program, and that's totally kosher. And then you bill for it under your MPI at the end of the month. 3 options here. Really 2 options with a third that is relatively nascent. First, you do it yourself, the cheapest. You're just paying for software and devices generally. But your staff are doing the calling and the management, all that good stuff. If you have the bandwidth for this, and you really can do this at scale, these programs are often the best run, maybe not the best run, but can be very impactful. Having it included in your general workflow, and the patient after a visit goes and sees the RPM nurse and is told about the program, there's value in that. It's impactful. That said, not everyone has that, so the other option would be to outsource, hiring a third party. I always say that there is no such thing as 100% outsource these programs. If you are giving away your patients arm's length and just seeing money come back in, you are not doing it right from both a compliance view and also from a general view. That said, number 1 here is maybe 95% you and 5% your vendor. Number 2 here is 95% your vendor, 5% you, right? Is the idea. More recent are hybrid programs. These are usually only done with large scale. We have a few of these where The hospital group's internal medicine is using us for outsource, but cardiology wants to do their own. So we have like across the parking lot groups, one that does one that, one that's doing the other. We also have some of these where we can help with overflow, but there's not a whole lot of vendors that do hybrid models. This is mostly because we're a software company first. So, we have that and the outsourcing, whereas a lot of outsourcing companies are mostly call center based. So, taking it away from them usually is not as, or having sort of both in and out can be an issue. That said, there's a few other vendors that do that. And it's worth considering if you really think you're going to hit scale and maybe will run out of bandwidth at some point, but want to still have the ability to grow.